question. This is a provocative question, Jonathan, so you be prepared for this one. We would let's say we have a randomized controlled trial with rotational atherectomy followed by a cut, a scope, or whatever you might on one end and lithotripsy to the other with a shockwave.
Yeah.
We might see, and this is kind of almost like a 5-point questions, right? Are you going to see better MSAs in which group?
Shockwave.
The shockwave. Are those going to reflect in long-term TLRs and things? Maybe
well,
not.
we know from multiple studies that MSA does predict long-term outcome.
But our trials, would it be powered enough to pick that up, you think? With the difference?
Well, I suspect if you look at the collective data now and you look at the long-term event rate, I mean, we've got so many registries. I mean, the India registry, the shock registry is the biggest registry worldwide so far.
Absolutely.
So I think we're going to start to get that long-term information. You know, I think we're probably getting to the 5-year point, and you know, maybe it's not quite 10 years, but it's. I don't have those concerns about late effects on soft tissue. I don't think there is a signal emerging.
Right.
I think there is a signal that has emerged in the past of patients who have high, barotrauma and lots of dissection, and I think so. I think you have to just go back to your. When you're choosing your first tool, there's a health economic question. But I would say if you're only going to use one balloon, then
that's the one.
That's the one I'm going to use. But really, it comes back down to safety of the procedure.